So what makes these time-limited regimens, a good choice for patients, as we've seen in the CLL-17 trial, it's non-inferior to continuous treatments. And when you have a time-limited treatment, you're just less exposed to toxicities. Our Bruton tyrosine kinase inhibitors that are used for continuous treatments do have, depending on which one you use, cardiovascular toxicities and risks of bleeding, which can be avoided with time-limited regimens. However, sometimes these regimens are a little bit harder to tolerate due to neutropenia, due to having to come in for infusions for the venetoclax ramp up. So either of these regimens can be useful. I think we're seeing that there's more data, especially for our patients who are unfit and have a lot of treatment interruptions, that they might actually benefit from just trying to push them through the time-limited regimen. We just have early data from the CLL-17 trial that shows that VI is basically non-inferior to Ibrutinib thus far. Will the curves separate out in the future? I don't know. The addition of venetoclax to a BTK inhibitor was also shown in that trial to have a higher rate of undetectable minimal residual disease. Does that mean those patients will have a longer overall survival? I don't know. But that might be some benefit to basically combining those regimens. Both regimens are all oral regimens, which patients will probably favor. However, venetoclax ibrutinib is not an approved regimen in the United States by the FDA due to cardiovascular toxicity concerns. So it will probably be acalabrutinib versus venetoclax that physicians are commonly using. What we saw in the BRUIN 313 trial, which compared Pirtobrutinib to the standard comparator arm of bendamustine rituximab, was a significant progression-free survival benefit with a hazard ratio of 0.20. So basically we're saying this is 80% better than the comparator arm. We're not really using chemoimmunotherapy in the first line in the United States anymore. However, based on that comparison, we know that Pirtobrutinib has a very strong improvement in progression-free survival. The main improvement that we see with Pirtobrutinib is the decreased cardiovascular toxicity and rates of atrial fibrillation, which I don't know that makes it so much different than zanubrutinib and acalabrutinib, which also have significantly improved cardiovascular toxicity profiles. Where Pirtobrutinib should be used in terms of sequencing therapy is an ongoing discussion, because if you use Pirtobrutinib first before the covalent BTK inhibitors, you're going to get basically resistance mutations potentially that would also confer resistance to a continuous BTK inhibitor. So maybe we don't necessarily want to lose that other line of therapy. However, if you have, a very old patient who doesn't want to do time-limited therapy, perhaps, and that you think is only going to be on one line of therapy, maybe Pirtobrutinib will be kind of a first-line option for those patients. But I think a lot more research needs to be done on Pirtobrutinib.